Paola. Me gustaría, first of all, agradecer a la Asociación Argentina de Medicina del Sueño y la Federación Latinoamericana de Sociedades del Sueño, en particular la doctora Stella Valiensis, por la invitación a participar a la Jornada de Medicina del Sueño del Cono Sur y presentar mi aporte como especialista en ortodoncia. From the beginning of my practice, more than 35 years, I've enjoyed working with children, helping them to achieve the proper facial growth. Moving the teeth, although very important, was not only my priority. I wanted to help children as they grew in a different way. I wanted to be an orthodontist from the beginning of my medical study. And dentofacial orthopedics, in fact, allows us to improve our way, change the growth of the children. We can improve the face appearance, and children can live in a better way their life, moreover, without psychological problems. That's why I call the rapid maxillary expansion a revolution in the treatment of OSAS children. We presented, it was 2002 when we presented Rmit in OSAS children for the first time in Rome. Then we presented Rmit in the treatment of OSAS children in the World Congress of Sleep Apnea in Helsinki in 2003. And we were the first with Dr. Guilleminot to publish this topic in the Journal of Sleep. After that, many researchers have conducted studies on this subject, confirming the importance of the topic. Above all, I'm really happy that many OSAS children are benefiting from this therapy. Today, Rmit has been recognized by the scientific community as an important contribution to the disciplined treatment of OSAS children. And one more time, I want to express my deepest gratitude to Christian Guilleminot. His belief in my work gave me inner strength as I innovatively introduced Rmit in OSAS field. It's very interesting to underline that at the time of our presentation in OSAS field in 2002, in the technical report of the American Academy of Pediatrics, the first-line treatment for OSAS children was adenotonsillectomy and the CHIP-up for non-surgical candidates. 2002, our first presentation and this recommendation. And after 10 years, the last clinical technical report of the American Academy confirmed Rmit as a valid alternative treatment. So now the scientific international community knows that the orthodontist can really play an important role in the interdisciplinary treatment of OSAS children. And Dr. Guilleminot, for a long time, underlined the importance of multidisciplinary collaboration in the treatment of sleep disorder breathing. He emphasized that orthodontic craniofacial abnormalities related to pediatric causes had been overlooked despite their impact on public health. And every time he underlined the importance of association between OSAS and maxillofacial malformation, he emphasized also that elimination of oral breathing is the valid finish line in pediatric sleep disorder breathing. We underlined for a long time that the interplay between nasal and oral breathing is well described in literature, but rarely investigated in clinical practice. However, this interaction has important consequences on the development of the upper airways in children, and it can promote the development of obstructive sleep apnea syndrome. We know that maxilla includes the external walls of the nasal cavity from the lateral side, and maxillary impaired development results in a decrease of nasomaxillary structure and then of the nasopharyngeal airway dimension. And despite I was a dentist, but actually an orthodontist, for a long time I've been studying Rmit also regarding its effect on breathing, hearing, and on the structure of nasal septum. And nasopharyngeal obstruction during development, as you know, leads to abnormal facial growth, resulting in mouth breathing, which results in sleep disorder breathing. And normal development of oral facial structures is important for exchange, particularly during sleep. For these reasons, we wanted to evaluate the role of rapid maxillary expansion in the treatment of OSAS children. We have successfully adopted Rmit for many years in all cases in which we want to obtain a skeletal expansion of the upper jaw. And as I introduce this topic in OSAS field, I want to remember the biological basis of this therapy and its skeletal effects, because these are the reason for the functional improvements in OSAS children. Then I show you also long-term follow-up study. Rapid maxillary expansion is based on the possibility to intervene through orthopedic forces and special procedures on the mid-palatal suture. I was very interested in this maneuver, so I deepened my study on the mid-palatal suture, and this is our lab specimen of the mid-palatal suture for a better understanding of this anatomic structure. Here you can see lamellar contact bone and in between highly vascularized fibrous tissue. At a higher magnification, tissue features become more evident. You can see lamellar compact bone and in between highly vascularized fibrous tissue. So I believe that rapid maxillary expansion is the best treatment for children with present a constricted maxilla that will lead to nasal dysfunction. And it's very important also to associate active myofunctional therapy. Rmit is indicated in every situation which requires the increase of maxillary diameters. And let's now see a clinical example. Extraoral examination, a typical phase of the oral breather. The profile clearly shows flattening of the mid-third of the face with labial incompetence, and labial incompetence with upper lip hypotonia, and thus increase nasolabial angle. Then the intraoral examination. We can see a bilateral and anterior crossbite due to insufficiency of the upper jaw, upper and lower arches. And here you can see the expansion sequence in the palatal view. And in the frontal view. Notice the bilateral anterior crossbite. After the first activation phase, the cross-sectional and sagittal relationship change, and the space appears between the central incisor. The diastema widens up at the end of the expansion phase, and the whole sequence from the front view clearly shows the change in the cross-sectional relationships. From the lateral view, the change in the cross-sectional and sagittal relationship. The dental profile and post, the pre and post Rmit. And now another clinical example. Tatiana, an extraoral examination, a typical phase of the oral breather. You see the profile that clearly shows flattening of the mid-third of the face with labial incompetence. The typical nasal features, labial incompetence, and upper lip hypotonia. And the intraoral examination showing the crossbite due to insufficiency of the upper jaw. The intraoral view, the upper arch showed the typical pattern of ogival palate due to the basal contraction of the upper jaw. Here you can see the expansion sequence and the phase pre and post Rmit. You can appreciate the difference in the labial incompetence for the improvements in respiratory function. Here you can see the posterior anterior telex ray examination pre and post Rmit, and the cephalometric tracing before and after Rmit, showing the anatomical changes The evaluation of the variation in the maxillary width shows an increase, confirming that Rmit maneuver directly influences the skeleton with the expansion of the mid-palatal suture. We can see a cross-section increase at the maxillary level, and the increase at the maxillary cross-section is also shown by the study of the nasal cavities, NCCN, that are widened by the maneuver with an increase in this case of a piriform opening of 5 millimeters. And we can see that the skeleton expansion caused by the maneuver occurs not only in maxillary arch, but also in the nasal cavity. Now, let me bring your attention to the expansion, the suture opening, the appearance of radiotransparency area, the bone distraction at suture level causes an actual widening of the maxilla, increasing its cross-section. We can appreciate a tangible cross-section increase in both upper jaw and nasal cavities. And the total expansion effects consist of a downward, forward movement of the maxillary complex with the resulting increase in all directions in the nasal canal. So Rmit maneuver is the best treatment for maxillary transverse deficiency because causes an increase in the nasal cavities, lowers the palatal wall, and improves nasal respiration. Because of these reasons, we have thought that Rmit could be an effective treatment in OSAS children. So we published in the Journal of Sleep the first prospective study of OSAS children treated with rapid maxillary expansion. In our first study, we investigated 31 children affected by malocclusion characterized by narrow upper jaw and with oral breathing, not due to adenotonsillar hypertrophy, snoring, and nighttime apneas. Patient underwent orthognathic investigation and ENT visit in T0, T1, and T2. Orthognathic investigation was performed using X-rays that included intraoral occlusal and teleposterior anterior cephalograms, ENT visit with the following tests: rhinomanometry, audiometry, and polysonography. And after Rmit treatment, the polysonographic evaluation in T2 demonstrated further improvement with significant difference, not only from T0, but also from T1. The results show an AHI of less than 1 event per hour in all cases. As you can see, the polysonographics show the change in the mean of AHI from 12.18 to 0.4, and oxygen saturation adhere from 78.5 to 95.3, with a complete resolution of clinical complaints. So our first results demonstrated that Rmit therapy has a positive impact on children affected by bronchopathy and mild OSAS. In case of sleep disorder breathing, it's important to evaluate the maxilla and consider Rmit treatment because Rmit changing the anatomic structure brings about a functional improvement. With this result, we announced that the orthodontist could play an important role in the interdisciplinary treatment of OSAS children. Now, let's see one more case. We know the typical face of oral breather and all these features. In the intraoral examination, we can see crossbite due to insufficiency of the upper jaw. And the diagnosis of upper jaw contraction is confirmed by the analysis of the posterior anterior cephalogram. So we can see the whole sequence of Rmit treatment from the occlusal view and the same sequence from the front view. the whole palatal X-ray sequence of the expansion. At the top, the suture hasn't expanded yet because the screw hasn't been activated. In the bottom left image, a radiotransparency area appears at the suture opening until the final expansion phase. And we repeat the expansion sequence examining the posterior anterior cephalogram. Here we can see the contraction of the upper jaw and of the nasal cavity with septal deviation. Please look at the septal deviation. Now let me bring your attention to the expansion. Suture opening, appearance of the transparency area, bone distraction at suture level causes an actual widening of the maxilla, increasing its cross-section, lowers the palatal wall, so the maneuver produces a tangible cross-section increase in both upper jaw and nasal cavities. And also we can appreciate the septal release. The whole sequence of the posterior anterior telex rays, we can see the total expansion effects consistent of a downward forward movement of the maxillary complex with a resulting increase in all direction in the nasal canal. A substantial increase is reported at the cross-sectional level with the relevant improvement in nasal airflow. These movements can also indirectly improve the oropharyngeal space by modifying the resting posture of the tongue. Here you can see the cephalometric assessment before and after Rmit, anatomic change in the whole sample. All cross-section diameters increase at the intermaxillary and intermolar level. Nasal cavities and intersphice space increase in width. In other studies, results are demonstrated as initially good immediately after treatment, but long-term follow-up is often lacking. And to avoid long-term relapse, we have to be sure that the skeletal effects obtained by Rmit therapy. So now I show you our study on multi-slice computerized tomography to evaluate the Rmit skeletal effects by CT images. We selected 40 children from 9 to 12 presenting a malocclusion characterized by upper jaw contraction, and because of this, they were treated by Rmit. Exams were performed with a multi-slice CT scanner with a dental scan reconstruction program, and the assessment carried out in T0 and in T1 were the evaluation of the mid-palatal suture opening, the width increase of the maxillary base, the width increase of the nasal cavities width, the first molar angulation, and the width increase of the pterygoid processes distance. And this is very interesting, the last parameter. We studied the mid-palatal suture, and the increase of the transverse dimension of the maxilla were measured at 3 levels on the axial scan parallel to the palatal plane. And we studied the maxillary base width, then we evaluated the nasal cavities, then we studied the first molar angulation, and finally, we evaluate the pterygoid processes distance, the distance between the apices of the pterygoid processes, left and right, was calculated on the axial plane. And these are our results, but it's more interesting to see the results on the images. So, the study of the variation of the maxillary width shows an increase, confirming that Rmit maneuver influences the skeleton directly with an opening of the mid-palatal suture. The study of the mid-palatal suture opening evaluated the Rmit effects by measurement at 3 different levels, anterior, medial, and posterior. And these results confirm the opening of the suture and also emphasize the form of the maxillary opening. Actually, the mid-palatal suture, because of the position of the maxilla in the cranial structure, can open in these triangular ways, a fun movement. And the increase of the maxillary cross-section is also demonstrated by the study of the nasal cavities that are widening by the maneuver with an average cross-section increase of the piriform opening, in this case in the average cross-section with an opening of 2.43 millimeters. And the study of the first molar angulation showed a minimal tipping of the teeth. This is a further confirmation of the skeletal effects of Rmit. Finally, the study of the pterygoid processus distance is very interesting. This is an important scientific evidence because actually this movement was impossible to demonstrate by the use of traditional X-ray examination. And this increase reconfirms the real skeletal effects induced by the maneuver. So in light of our experience of the positive outcome of orthodontic treatment using Rmit, we studied our sample of children diagnosed with OSAS and treated with Rmit during prepubertal years, and we presented a long-term follow-up study for the first time at the International Pediatric Sleep Association Congress. Then we published the study with Professor Guilleminot on the Journal of Sleep, and the aim was to evaluate the long-term efficacy of rapid maxillar expansion in a selected group of OSAS children. And this is the longest follow-up investigation of OSAS children treated with orthodontics. These are our results after Rmit treatment. As we saw before in the first study, the apnea-hypopnea index decreased. As you can see in the polysomnography, show the change in the mean of AHI from 12.18 in T0, 0.4 in T2, and oxygen saturation nadir from 78.5 to 95.3, with a complete resolution of clinical complaints. And 12 years after the end of the treatment, as we can see in T3, no significant changes in the apnea-hypopnea index in other data were observed. And as we can see in the result published in the Sleep Medicine Journal, and the last evaluation in T3, the 23 patients with a continuous follow-up had no indication of OSAS recurrence. As you can see, they are in a normal range. There was no clinical complaints and no abnormal findings. So this is the longest follow-up study of OSAS children treated with orthodontics presented today. And our results show that Rmit is confirmed as a useful approach in children with malocclusion and OSAS, as the effects of such treatment were found to persist for a long time after the end of the therapy. In some studies, we can find residual problems, for example, after only ENT treatment. And these results are associated with abnormal craniofacial features and untreated nasal resistance. This is very important. And Guilleminot underlined that at the basis of the residual problems were untreated craniofacial problems. In fact, in our paper, we conclude that in presence of sleep disorder breathing, it's important to evaluate the presence of orofacial abnormalities, as these factors may be associated with the recurrence of OSAS symptoms. So to avoid relapse and recurrence of the symptoms, we have to really change the anatomic structure to retain the expansion achieved, performing also myofunctional treatment and respiratory reeducation training and therapy. The fact the functional improvement can be clearly linked to the skeletal expansion caused by the maneuver, as we can see in the sample, the CT of maxilla pre and post Rmit. We can see that the total expansion effects consist of a downward forward movement of the maxillary complex with a resulting increase in all direction in the nasal canal. A substantial increase is reported at cross-sectional level with a relevant improvement in the nasal airflow. As you can see in this image, these movements can also indirectly improve the oropharyngeal space, modifying also the resting posture of the tongue. For these effects, Rmit also allows mandibular forward movement, as this further contributes to improvement of the functional breathing. As we can see in this patient before Rmit, we find a typical phrase of oral breather with typical features, upper lip hypotonia, labial incompetence. And in this case, in the lateral view, we can see also the mandibular retrusion. In the intraoral view, we can see the contraction of the upper jaw and the mandibular retrusion. And in the lateral view, we must remember that during the facial growth, maxillary contraction is one of the main reasons of the mandibular retrusion. And here we can see the rapid maxillary expansion treatment sequence. And we can know the important changes in the palatal arch just after Rmit. And the final result showing the change in the face and in the occlusion. We can see the mandibular forward movement thanks to maxillary expansion. So Rmit and associated orthodontic movement can also increase the oropharyngeal space, allowing mandibular advancement and modifying the resting posture of the tongue. In fact, the dimensional change of the maxilla leads to important changes also in the posture of the tongue. And to achieve this, after Rmit, we utilize tongue posture rehabilitation for a long time. So before Rmit, tongue posture is low and the oropharyngeal airway is narrow. And after Rmit, tongue posture has improved and the pharyngeal airway has enlarged. The mandibular forward movement increases the space between the posterior pharyngeal wall and the tongue base. And so Rmit treatment allows the result to be much wider than before the treatment. And this decompresses the pharyngeal airway and therefore reduces OSAS symptoms. And there are still others, but we have no time today. And now we can see our last clinical example, extraoral examination and intraoral in the front view, the evident crossbite due to insufficiency of the upper jaw. The expansion sequence, the frontal view from the beginning of the treatment to the end of the activation phase, when we block the screw. Here you can see the effects of the maneuver, examining the posterior anterior cephalograms, which show the contraction of the upper jaw and of the nasal cavity with septal deviation, and after Rmit, the suture opening. And here the cephalometric tracings before and after Rmit showing anatomic changes. As we know, the skeletal expansion caused by the maneuver occurs not only in the maxillary arch, but also in the nasal cavity. And the same patient, CT scan showing the sutural opening. and the opening of the mid-palatal suture in the palatal view in the volume rendering, and we can see the skeletal effects of the maneuver. The widening of the nasal fossa and the septal release, restoring normal airflow. It's this very anatomic change which brings about an increased patency of the upper airways. That's the foundation for the positive effects induced by Rmit also on the respiratory function, with a net improvement of breathing disorders during sleep. As you can see also in the volume rendering, and the functional improvement can be clearly linked to the skeletal expansion. Total expansion effects consist in a downward forward movement of the maxillary complex, with the resulting increase in all directions in the nasal canal, with the relevant improvement in nasal airflow. So rapid maxillary expansion and directly improves also the oropharyngeal space, modifying the resting posture of the tongue. Now, to conclude, we can study the follow-up. And here we can see the long-term follow-up of the same patient. Rmit should be considered essential in the protocol for pediatric OSAS patients. Changing the anatomic structure, Rmit brings about a functional improvement. And to avoid relapse and recurrence of the symptoms, we have to really change the anatomic structure and to retain the expansion achieved, also performing myofunctional therapy and respiratory re-educational training therapy. Interdisciplinary collaboration is fundamental. So we can study long-term follow-up of our patient. In the palatal view, we can see the 3 different stages. The follow-up shows the stability of the obtained results. And the mid-palatal suture, the specific scan, we can see in the follow-up the mid-palatal suture reorganized in its structure. The expansion achieved is well conserved, as we can see the improvement in sinusal ventilation, which is clearly documented by the progressive disappearance of the phlogistic fluid retention. This effect starts immediately after Rmit, and in the follow-up, we can not only see a maintenance of these effects, but we can see also a net improvement of this effect. And the CT scan shows in the right sinus, we can verify a full air restoration in the left sinus. A small osteoblastic reaction of bone wall persists, but without an increase. This is evidence of previous inflammation. And the study of the base width confirms, as you can see, the long-term stability of the expansion. And the study of the distance of pterygoid processes shows the real skeletal effects of the maneuver after Rmit. This is a very important scientific evidence because in the past, this movement was impossible to demonstrate by the use of traditional X-ray examination. And now the CT imaging allows us to verify the movement caused by the Rmit. This increase reconfirms the skeletal effects induced by the maneuver that lead to a real remodeling of craniofacial structure. And the follow-up is a very important evidence that confirms the stability and the maintenance of anatomical changes induced by rapid maxillary expansion. So finally, here in the volume rendering imaging, we can see all the sequence and the long-term follow-up. These images clearly show the important skeletal effects induced by the maneuver and their stability and the long-term evaluation. This is why rapid maxillary expansion should be considered essential within a therapy protocol for pediatric patients affected with OSAS. It also is important to assess the condition of the upper jaw in order to consider Rmit therapy in the multidisciplinary treatment of OSAS children. Because changing the anatomic structure, Rmit brings about a functional improvement, but we have also to maintain these results. In fact, in our study, we showed that the children with the specific anatomic presentation as small tonsil and adenoids might not need an adenotonsillectomy surgery. Also, children with maxillary narrowing and followed up in the adult present stable long-term results post-Rmit treatment for pediatric OSAS. So the orthodontist can really play an important role in the interdisciplinary treatment of OSAS children. I want to really conclude that Rmit should be considered essential in the protocol for pediatric OSAS patients because changing the anatomic structure brings about a functional improvement. So interdisciplinary collaboration is fundamental. We can really play an important role and we can help OSAS children. And I'd like to conclude that for a long time as an orthodontist, I understood that giving a child a beautiful smile was a gift from God. And helping a child to breathe, it's an even greater gift, which gives me a lot of joy. Thanks God. And thank you for your attention.